Hi, my name is Dr. Shannon Vogt, and I'm going to be talking today about setting expectations for students in clinic. I am an associate professor of family medicine at the University of Kentucky in the Department of Family and Community Medicine. I work with students and residents in both the clinic and the hospital setting. So really this is applicable to students and residents, clinic and inpatient, but I've kind of tailored the discussion today for clerkship students in the clinic setting. So our objectives are to state the role of the student in the clinic environment, to set expectations for the student and use the mnemonic orient to recall these steps, to practice using priming as a teaching tool, to correctly supervise the student for clinic visits and documentation, and to practice using precepting in the patient's presence versus traditionally in the staffing room, and to start involving the student in counseling and care management. So what is the role of the student in the learning environment? Well, that's pretty simple. The role of the student is to learn. The student wants to learn, but what is it that our students need to learn? And that can depend. So it depends on what you're teaching and what field you're in. So from one perspective, they need to learn about the field that we're in. So for me, they need to learn about what I do as a family medicine physician, what my life is like, what clinic is like. They might not want to do that field. And so I want to show them how we can work together in whatever they end up in. Or if they do want to be in my field, then we might want to teach them something different. But really, I want to teach them as much as I can about the specifics of the work in family medicine. They also have, required objectives in their clerkship, and they will have required clinical experiences. So when I look at those, I can see that, for instance, I need to make sure that they see certain types of patients and types of cases. They need to practice taking a history and performing an exam, because those are all part of our course objectives. Clinic can be a tough space for an adult learner because clinic is kind of a foreign space for them. A lot of students have mostly been in the hospital, and it might feel like they're on somebody else's turf, or they might be in a clinic that's outside of their hospital system. So they're unfamiliar with how the clinic runs or with the EMR. So we really want to help them to learn, but there's different ways that we can do that well. So in order to understand how students want to learn, we have to understand how adults learn. And our students are adults. So adult learners are internally motivated. We know that our students, they want to be physicians, they're motivated to do well. They should be somewhat internally motivated and self-directed. They have life experiences and they have knowledge that they bring to these learning experiences. Especially if we get them in third and fourth year or in residency, we know that our learners have already had prior experiences that they're bringing in. Our learners are goal-oriented, so they have goals, they know what they're working for, hopefully, or they might need us to help them figure out what their goals are. They're also relevancy-oriented. They really need to understand why they're learning something, not just given things to learn or memorize, but see the point and the importance of that to the rest of their career in life. Adult learners are also very practical. They like to learn skills that they can repeat in the future. And most of all, they like to be treated with respect. So when our students are learning in the clinic, what are some ways that we can help them to learn? So first of all, hands-on learning versus modeling. So for the most part, hands-on learning is how our students want to learn, right? It's practical, it's relevant, it's more interesting for them. So adult learners learn best when they're invested in that learning process. So sometimes they just need to start seeing patients and doing it on their own, and that is the best way for them to learn. Modeling is sometimes like shadowing, and shadowing is usually as helpful for students because it can be boring. So you're risking it being boring for them. But modeling can be helpful in certain cases. For instance, if you're managing a really complex or difficult case, or delivering bad news or dealing with something difficult, And in those cases, you want to give the student something specific to watch for so they know what they're modeling. So you might say, hey, we're going to go in and see this patient, watch how I deliver bad news, or watch how I manage this patient with multiple medical problems who's really complex, and how I kind of set the agenda or determine what we need to talk about today. Exposure to clinical cases is important. So our students need to see a variety of cases to cement those concepts. So they shouldn't hopefully be seeing the same thing over and over. That being said, let's say they see an initial patient who's there for, say, arthritis, and you discuss the exam and the management and the workup, and maybe they struggle with that first case. So maybe you have another case of a similar patient and you can send them in there, and now they've done it before. So they can feel more confident, kind of like see one, do one, teach one. Students also enjoy variety. So in general, again, like I try to give them a variety, but maybe they've done a couple of things several times during the course of a month, and I can see them improve, and they really enjoy seeing that in themselves too. So I'll say, hey, remember when you first saw that first patient with this problem, and now look how expert you are at managing this. Students need to practice and cement their skills in obtaining a history and performing a physical exam. Obviously, this is a requirement of student clerkships, but this is also something that they're there to do and to become more confident. We also do need to observe them doing this sometimes and not just trust when they come out of the room how they've done it. So we call this direct observation, and that's where we ensure that they are doing it correctly, and that we're giving them guidance and coaching on how to improve. Students also need to practice forming a differential diagnosis and coming up with an initial management plan. For instance, we talk about the 1-minute preceptor model. So we encourage our student to come up with a differential by asking, what do you think is going on? What else could be causing these symptoms? What would be your next best step? So trying to really probe and get the student to come up with a plan, because usually this is where they are going to struggle the most, right? Is coming up with a differential diagnosis and forming a management plan. We also want to know what the students' goals are and their interests and needs, and that will make it more relevant for them. So what I would suggest is at the beginning of the rotation or the beginning of the day or week, you ask the student, what are their goals for that day? What are their goals for the rotation? Is it practicing a certain exam? Is it presenting? Is it forming treatment plans? Or is there just a certain type of patient they need to see because they haven't seen that yet? So then if you set a goal at the beginning, you can kind of be more in tune and watching for that throughout the day. So if they have a goal of presenting a differential diagnosis that's complete, then you can be watching for that and say, hey, I noticed that you came up with 5 different possible causes for this knee pain. So good job. Or, you need to improve in this area. And students also need frequent small doses of feedback to keep it relevant, to keep them motivated. So, after each patient, I might say, hey, I like that you included this or that you did this appropriate exam. So trying to give them a little feedback, just little bits after each patient. And then, of course, we have bigger moments of feedback later on in evaluation throughout the course. And then you might say, next time, try this, when you're seeing a patient, like make sure you examine their gait or their reflexes. So those are all ways that students learn well in clinic. But first, we have to know that even the best students can't perform well if they don't understand the expectations. You have to know where you're going. So how can we do this? We have to give direction. We must tell them what we expect. So how do we set our students up for success? First, we want to ease them into more responsibility. So obviously they are unfamiliar with your clinic initially. So we need to orient them to that process. This is the nurse, introducing them. This is how the patients come in and where they're roomed and where they check out. So they kind of understand the process. So yes, the first day or two, they might do some shadowing or might kind of only see 1 or 2 patients just to try to get into that flow. But then as the rotation goes on, they can do more and more as they become more confident. I think introducing them to staff and empowering them to ask staff for help or for questions. So for instance, this is my nurse, and if you need an A1C or a urine, like feel free to ask her for help if you want to recheck the blood pressure. So those kind of things. We also want to give them a primer on expectations. How long should they be in the room? How long should they expect to talk to each patient? What kind of notes do we expect them to write? What are their jobs? So we'll go through this in more detail, but we don't necessarily want them to see every single patient. We want them to be able to learn. So sometimes that means seeing fewer patients and learning more. So I like to review my schedule and say, I'm going to plan on having you see these 3 or 4 patients. You look through their chart and prepare so that they can learn more about that patient and be more of an expert. So let's talk about an example case. So you arrive in clinic and see that your first patient, an elderly patient of yours with multiple problems that you have known for many years, is ready to be seen. You send your brand new 3rd-year student in the room, and 50 minutes later, the student is still not out of the room. So what do you do? I think for those of us in clinic, we've all been in this situation before. It tends to happen earlier in the year. And what could we have done differently? Well, we have to remember this is a new 3rd-year student. They're new on the rotation. This may not be the best first patient for them to see. That being said, like maybe that patient's really enjoying the time with the student, so that's okay. But I think we could choose to go interrupt and kind of go in and finish up the visit, or we could just wait and see what happens. If we have other work we can finish. When we have really complex patients that we know really well, as you can tell, that's probably going to take some time for a student to get through. A student may not understand the expectation that they don't need to do a full past medical history review with every patient. They don't maybe understand in your clinic that you maybe do a more focused exam, or that you wanted to focus just on one problem today with this patient. So you know this patient well, so you can kind of just talk about a few things and not everything, but a student might not understand that. So I think it's helpful to give the student a little bit of a primer. So, hey, we've been talking about this patient's depression, so that's mostly what I want you to focus on for today, is how that's going since we started this new medicine, or the blood pressure, or just focus on any acute concerns they have. Don't try to get into everything. I think it's helpful to give them some expectations initially on how long they should be in the room or what the goals of the visit are. I think sometimes I send students in the room and they just try to do everything. So we do try to teach them in our clerkship about setting an agenda, but I think they need to be reminded about that, like that you can't really go over everything. So maybe focus on one acute concern and their health maintenance or something like that. So the other thing to think about is, what do you want the student to learn? So the student's here to learn. So what are they learning with this patient? Are they just learning how to talk to older adults? Because if that's the case, then say, I just want you to go in there and talk to them as long as you want. Or do we want them maybe to learn about how to manage diabetes or hypertension? So in that case, we want to give them something specific to focus on. Or we might want to model this patient in terms of they're really complex. So why don't you just come with me? Or skip it and wait for the next patient to come. So what is priming? Priming is really important. And as I've gotten more and more into this work, I noticed that I prime my students a lot, partly because I want to avoid situations like the last one where it's an hour later and I'm kind of just haven't really accomplished anything that I need to accomplish for that patient visit. I'm a pretty efficient worker, so I tend to want to prime my students. I give them too much info, I don't know. But priming is where we set the stage for expected learning. So this is our patient, this is the situation, this is what you can learn from this. So we had a patient this week that was newly pregnant unexpectedly. So before the student went in there, I said, hey, we're not doing like a prenatal visit, this is just a new pregnancy. We're going through, how do they feel? Ask them open-ended questions. Don't say congratulations. Say, hey, I heard about the pregnancy test. Like, how are you feeling? So we kind of went over how to kind of approach that. And then the main goals of the visit would be managing symptoms, going through medications, and making sure there's no risks that we need to deal with immediately. So I set that stage in a pretty detailed way because that student had never seen a pregnancy before. So, if it was maybe a student that was further along or a resident, I could just prime them more briefly on how to go in there. So as they get more and more into training, they won't need as much priming. Eventually, they don't need any, right? We're also trying to just prepare that learner's mind for the task. So for instance, a patient's coming in with an acute concern. We want to start getting them ready for the differential that they're going to have to form so that they can stay on track with that. So how might you prime a student before seeing a patient who has a chief complaint of cough? So we might say, so the patient's coming in for a cough for 6 weeks or something like that. What kinds of things do you want to think about before you go in the room that you want to make sure you ask about? And that might be even a little mini teaching that goes on, like, hey, just so you know, we really differentiate between acute and chronic. So acute cough has a certain differential versus chronic cough, our differential kind of changes. You want to think about if you're thinking they have asthma, what kind of questions you might ask, or what kind of medicines might you want to look for. So not to do all the teaching before they go in, but just to kind of prep them just a little bit to get them ready to learn and focus on what they need to learn. So thinking about specific encounters in the clinic, you also need to think about what do you as a physician need to accomplish in the visit. So if the patient is here for a specific procedure, you really can't have the student go into a lot of other things. So you might need to prime them to focus on certain things because you do have to accomplish something. We also want to think about what the student can learn. Is this a good learning opportunity or not? Maybe we should skip it. And if it's not a good learning opportunity, is it a modeling opportunity versus just, they can wait and prepare for the next patient? What can my student learn? Well, sometimes there's not a lot. And I think, well, it's a Medicare wellness visit. I don't really need them to know all the insurance aspects of that. But we can definitely go into talking about how do you do an advanced directive and goals of care discussion. That's a great learning topic. So kind of trying to pick out 1 or 2 things that they can learn to keep it a little more reasonable for them. You also think about what is realistic for, whether it's a 3rd-year medical student, 4th year, or resident, what is realistic for them to accomplish? Can they see 10 patients a day? No, they really can't, and they probably shouldn't, and will be overwhelmed and overworked. So if they can see maybe 6 to 8 patients in a whole day in clinic, at least for family medicine clinic, that's pretty reasonable. Now, if you're in a surgical subspecialty, they could probably see a lot more. So it just depends on your clinic and your patients, and then what that student is able to do. But I would definitely advise against overloading them with complexity, because that can just make it feel like they're kind of digging their way through notes and problem lists and not learning. Be aware that some 3rd years may be more capable than others. So I know we all have had students in clinic that can just do so much and get so much done, and you're really pleased to see that they're there because they really help your efficiency. And then there might be other students that take a little more hands-on help and hands-on learning, and they tend to miss some things. So then you have to go back in and do more. So I do think that you have to kind of tailor to where they're at. That could be just where they're at in the year and what they've already done, so if they've already done pediatrics rotation, I don't feel bad getting them to just do a well child without much priming at all. But if it's their first well child ever, I'm going to do a lot of priming to prepare them for that visit. So as the month goes on and you're working with a student more and more, they're capable of more. They understand your approach. They get to know your approach. And I think you can kind of expand their responsibilities. So when we talk about actually what's required for supervision for medical students at the University of Kentucky, we do have some requirements for what's required for supervision for students. Now, this is ours for family medicine, but each clerkship should have one. So what's required? Do I need to be in the room while they're doing things, or can I just be available? So what we've said is that you just have to be available for the history and physical communication and writing notes. But obviously for procedures and for sensitive exams, I need to be standing there right next to you, right? So this is what's required for supervision. And generally you just have to be available. And that could be even over the phone, which would allow you to do, say, a telehealth visit. And you might be at your house and the student might be somewhere else. And that could technically work well because you can supervise them digitally, electronically. But can the student start seeing patients before you arrive in the morning? Yes, because you're available by phone, you're on your way. But they shouldn't be doing procedures or things like that by themselves, obviously. For documentation, your student can write your notes and they can provide independently the history, but you need to attest to that your physical presence in the visit so that you were involved in the exam and the medical decision making and that you confirmed the history. So this could be either you or a resident with the student and the patient. All three at some point have to be in the room. So you can't have the student see the patient do all the work, come out, and then you send them on to the next patient and you go in by yourself and check things out with the patient. You have to all three be there to really say that you were physically present. So that is kind of important. And when you actually write the note, or the student writes the note, you will attest that you confirmed the history and performed your own exam. And you can use something like this. I saw and evaluated the patient with the medical student. I discussed the case with the medical student and agree with the findings and plan as documented. I personally performed the exam and medical decision-making. So let's talk about a mnemonic to kind of remember all of these things. And this is called orient. So O is for orientation. So when the student arrives brand new to your clinic, you want to discuss mutual goals. So what are the learner's goals for the clerkship or for the course? What are their expectations? What are they wanting to learn from this? Because everyone's going to be in a different place and they all have the same things that they need to learn, but some will be, wanting other things as well. It depends on what their career interests are. So I think it's helpful to get to know your student and to understand what their goals are. And you might want to tell them why you enjoy teaching. R is to go over responsibilities. So what do you expect from the learner? So what time do they need to be there? What time should they expect to get lunch or to go home? Do you typically work through lunch and leave early? I mean, these are all things to kind of be aware of for the student so that they can be more comfortable coming and going or being there when the learning is happening. How are you going to supervise them? Where do you like to do your teaching? What are the expectations for charting or for reviewing patients before they go in? When is feedback going to occur? So, in our rotation, we send you a mid-clerkship feedback that has to be done by the second week, but it can depend on how long the course is when you're going to do feedback. I is for interchange, and this is just referring to how to balance things between service and learning. So for instance, we're there to learn, but they also do need to complete their notes and their work and help you complete your work. So how do we balance that? So sometimes I'll say, wow, this next case is a really good learning case. Why don't you pause that note you're working on and go ahead and see this patient, and then I will give you some time after that to catch up. So I do kind of keep in mind my students needing to document things and trying to give them some time to balance the learning that they have to do, but then also the help that they're there to provide me. E is for education. So what do you suggest that they look at to learn? What are good learning resources? Maybe you have a go-to source that you use when you're in clinic and you have a question, or you have good apps that you use. So I know that students love apps and they've shown me things like that I didn't know about. And so I think it's good to kind of look at those and see if they're any good. But really, they're going to be learning mostly from you. And as for needs, what can I help you with? What's going on in your life? A lot of times students are living somewhere new, staying with a housing host. They've never been in that community before. Maybe they need to know like where to get groceries or where's a good place to get coffee. What can I help you with to get used to this community and what we have going on here? I think the coolest thing about our AHEC rotations is that students really get to know a community, and that's a really great experience for them. And you are the expert on your community. And T is for timing. So when are we going to touch base about these goals? So sometimes I'll say, okay, we'll talk about this goal at the end of the day. But obviously some goals we'll touch base on at the end of the whole course. So when will we come back and kind of see how things are going? Next, we'll move on to presentations and expectations for that. So think about how you have a student present to you. And I would encourage you to have them present and allow them to complete the whole SOAP presentation. So a lot of students give you the subjective and sometimes the objective, although honestly, a lot of times they forget that. And then they just pause. And I think if we jump in and start telling them what we think we should do, we're not allowing them to learn. I think students are hesitant to go ahead and give their assessment and plan. So I try to say, okay, what's your assessment and plan? Go ahead. So I try to encourage them to finish. And then when they're completely finished, I'll start asking them questions or going through details so we can come up with a final plan. And typically this is done outside of the patient room at my desk area. So we call this traditional or conference room staffing. And it takes a little bit of time. So as you all know, when you're running way behind and there's like 4 more people waiting in rooms, this can feel a little bit rushed to have to sit out and listen to everything and then go back in the room with the patient and the student. So I would like to encourage you, especially in those moments, to try precepting in the patient's presence to save time and to also improve your patient experience. So precepting in the presence of the patient has been studied. This is a randomized trial from 2017, but it's basically an effective method, particularly in family medicine clinics, because with time constraints, it's really this time efficient method that was very well received by students. They asked patients, physicians, everybody thought it was fine. And it actually gives you more time with your patient and less time overall in the encounter. So it saves you time. You get to spend more time with your patient. And really, I think when the student presents in front of the patient, they spiff everything up. They make sure everything's really good because they're presenting in front of the patient. So they want to look good. They want to get everything right. So actually I tend to find that they stay a little more organized. And I also get to see how they kind of interact with the patient. And if they missed anything or if the patient has to clarify anything. So it's a little bit like of a direct observation there for your patient. So how do you do this? Well, I do think when you try to practice PIP, you need to prime your student. You also need to prime your patient. So I try not to just throw them in this process the first day. So the very first day, I probably wouldn't do this. But maybe by the second day I would. And I would say, hey, since, we don't have a ton of time, I'm going to have you present in front of the patient. So just present like you normally would. And I will explain it to the patient how it's going to work. And I want you to go ahead and try to give me an assessment plan, even if you're not sure. The student's like usually a little hesitant, says, okay, and usually I'll say, is there anything you need to tell me that you feel like you can't tell me in front of the patient, and sometimes that might be a patient you don't want to present in front of if there were concerns like about the patient's safety or things like that. But usually they say, no, everything's fine. So we go in the room and then I'll tell the patient, hey, I'm going to have this student present to me. They're going to tell me about you and what you guys talked about. So you can just listen, but feel free to chime in if you want to correct anything. So I do prime the student and the patient, and that usually helps. Let's say you're in the room and the student starts presenting the history and exam, but then they just stop. What do you do? So I think in front of the patient, it can be really hard for the student to step out on a limb and say, this is what I think it is. So sometimes I'll ask them like more specific questions, but I'll say, well, what do you think might be going on? Because we know that the student might be wrong. So we don't want the patient to think this is definitely what it is. We'll say, what thoughts did you have? Like, what do you think might be going on? Or do you think these two symptoms are connected or separate? Or, you know, so I'll try to give the student some opportunity to give me a little bit of a plan. And then I'll just basically do my teaching in front of the patient, where I say, wow, sounds like you had some good ideas. I think it's most likely this, and this is why, or let's do this exam. I noticed that you didn't do this, and this will help me decide what we should do. So I think that's actually a nice learning experience for the student, but also for the patient too, really, because they can see that learning environment. I think patients really enjoy seeing you teaching. They're like, wow, my doctor is a great doctor because they like teach other doctors. So I think it can turn out really, really well. And again, it saves you time. So last little thing, we're going to talk about counseling and care management. I think it's actually really good to involve students. I don't know that this is something that they can do immediately. This is more, helps them to be more engaged though with patients as they go through that clinic month. So usually what happens is the student does their whole history, exam, assessment, and plan. And then you go back in the room and you kind of explain, it's your patient, you know them, you're going to tell them. Sometimes, especially when the students built good rapport with the patient, I want the student to give them the plan. And this is something we actually prep them for in our orientation, where they practice explaining things. I think this is really great. Typically you're in the room observing them. So it's a good way to observe your student. You can watch for if they use medical jargon, how well and slowly they talk. Are they able to communicate well? Which really helps you in your evaluation of them. How is their bedside manner? And do they use teach back? Or, so it really gives me a lot of teaching points for just patient communication skills. So I do like to have my patients go back in the room, my students go back in the room and explain the plan. Typically, again, for less complex cases, and maybe for patients that I know not quite as well, because I know if they know me super well, they might want to hear from me. But that's because it's clinic and, it's just a slightly different environment. I think in the hospital, I always have the student give the plan, but in the clinic, it's just a little different. I also think you could have the students call patients if you're sitting there looking, oh, the labs came back from this patient we saw earlier. Do you want to call them and tell them that they were normal, or that the x-ray didn't show this or that? And I'm usually right there. And so I can kind of make sure this goes well. If the patient has any questions, that I'm there, but I'll have the student call and go over that. And I think that's actually a really good experience for them, that they really don't get to do much. So they'll remember that for a while. Or maybe you have a care management team, so a social worker or someone else in your clinic, and you can have the student talk to them about a case. So just as a practice, say that your student presents a patient case to you, and the patient has had 5 days of nasal congestion, low-grade fever, and a cough, and the exam was consistent with a URI. And the student kind of gives you their whole presentation. You feel like the student has built pretty good rapport with the patient, and you feel they could explain the plan. So how do you prime them to present the plan? So obviously you want to get your differential from the student, but you do want to kind of clarify what you think is going on and make sure that the student presents the correct plan. I might kind of go in there saying, hey, when patients want antibiotics and we don't feel like they need antibiotics, sometimes I say this to make it easier. So I might help prime them. And then we'll go in the room and I'll say, hey, I'm going to have student so-and-so explain to you what we were thinking and what we wanted to do. And the student will go and they'll try. And I think usually they do a really good job. And sometimes I'll just step in and add a couple of my own thoughts. And I think it goes really well. So we can kind of prime them to present the plan as well, so that they can do that successfully and practice talking to patients. We also teach all of our students a patient-centered care lecture where they practice not gathering history, but setting an agenda with patients, and where they practice explaining findings to patients. So they should have done this, and I love it when they get a chance to practice. So I hope you enjoyed this presentation and that you found some helpful tips. I thank you for all the work that you do with students, and I hope that you can continue to grow in your role as a teacher.